Okay, so we're joined today with Dr. Michael Repka. Welcome.
Thank you.
I wanted to talk to you a little bit about your role at Wilmer Eye Institute. If you could talk a little bit about that first in this current pandemic that we find ourselves in, and what changes you've made and adapted.
Thanks. So the vice chair for clinical practice has long been mostly about teaching compliance and making sure that the clinicians were following the rules for coding or reporting and looking at volumes of patients, but it was largely about rules. The change, of course, in this period led to the need for communications, and I viewed the initial steps as a communication between our administrative team, who was in contact with Hopkins leadership, both for epidemiology and infection control, as well as for the clinical practice. What were we going to do? How were we going to do it? When were we going to do those things? And that really ended up being communication, initially with daily calls for the division directors, subsequently 3 days a week, and now we're down to 1 day a week with providing information, answering questions, really a conduit of information. In a big place like Johns Hopkins, it is easy to not figure out where the rules are coming from or even what the rules are.
Mm-hmm. Well, it's interesting because you are also in your very unique position that you are the medical director for governmental affairs with the American Academy of Ophthalmology. And so in conjunction with their guidance that they've been offering and issuing in conjunction with everything that's going on, how do you find your two roles kind of interplay with each other?
They're entirely symbiotic roles. The difference, of course, is at Hopkins, I worry about the academic practice and how it works, where we have an overarching set of principles that come to us from leadership. It's also institutionally based for many of our clinics, but not all. About half of our clinical practice occurs in other locations that are not typically hospital-based facilities. The academy role, of course, was about providing information to the broad spectrum of ophthalmic practices, from solo practitioners to the academic institutions. But really, the information necessary was for the small practices for the academy. And that was a role that they provided early on with various webinars, with daily briefings to provide information to those people that didn't have overarching leadership telling them what they should do.
Mm-hmm. Okay. And so I just kind of wanted to ask you a little bit more about that. Since the pandemic began, what has been a major leadership challenge that you've had to deal with?
Perhaps the biggest, and it's probably a nice one, is the wish to get back to normal by our providers. They really want to do patient care and not have people waiting for medically necessary procedures. And yet the responsibility to make sure that our staff, the providers, the doctors themselves, and our patients are seen in a safe manner. So really, it's getting those processes out and disseminated and implemented.
Mm-hmm. Okay. And so, as you know, in March, the Academy issued practice guidelines with regard to what emergent procedures could be performed. Could you talk a little bit about how you've made that transition from emergent to now, as we resume practice, some changes that you've made at Johns Hopkins?
The issue, of course, of stopping elective surgery was important to preserve resources. Now, the issue of rebooting or relaunching the clinical practice is a bit about, are resources sufficient so that our providers, the teams that are working in the hospital in more intensive situations with viral infected patients, have access to sufficient PPE. Assuming that's the case, then it's really a question of how to provide elective and semi-urgent and urgent care that we might not have been doing as expeditiously in facilities that also have to be safe. So that now the restraints are, how in our ASC can we keep patients from being next to each other in pre-op and in post-op beds, and where they should stay. Similarly, in larger hospital-based operating rooms, it's taking those same large PACUs that may have held 10 or 15 patients and saying, wow, we can't do that anymore. How are we going to get the patients in and out of the facility as well? Where we're going to put their friends, their accompanying people, so that they don't provide another source of potential infection for our patients or our staff. So it's a bit more about logistics and how to ramp up safely.
Mm-hmm. And could you kind of walk us through some of the impacts that are affecting your surgical decision making in this whole, special considerations right now for surgery?
So the impact on surgery is somewhat availability of OR time and availability of patients. One of the unforeseen things was that if you weren't seeing semi-urgent or elective patients in your office, you actually did not build up a huge backlog of cases. Now we're starting to develop that backlog because the clinics are reopening, and so now those patients are getting into the queue, and yet we still have to manage those patients that were canceled week after week after week during April and May and into early June. So it is a capacity that's still reduced, and it is a volume of patients that we have to get through. Now, it turns out that doctors' time is helping manage that. It's not as if our doctors are available every minute to get all of their cases caught up. And so we're finding that just using some limits on OR is allowing us to get cases from each of the ophthalmic disciplines done.
Mm-hmm.
So we're not really excluding anybody with important medically necessary diseases. There may be some patients with minor plastic surgery, perhaps, that may be postponed, or a child with a chalazion that you would say, you know what, this we probably should wait on. But we haven't had huge backlogs in terms of managing patient throughput. And maybe that's our clinicians have been able to say, you know what, this patient needs to go, and I'll just go slower on other patients.
Mm-hmm.
So I think the clinicians have really stepped up and helped us with that triage.
Mm-hmm. Mm-hmm. And with regard to some aerosol generating procedures, what steps are being taken with regard to that?
So the aerosol generating procedures, fortunately, are relatively few in ophthalmology. For our institute, we mostly worry about procedures that go into the nose.
Mm-hmm.
So that those might be a dacryocystorhinostomy or similar procedures, nasolacrimal intubation. You may say, you know what, we should postpone those for a moment. Where they're truly necessary, perhaps infection, then of course one has to do the full court PPE with N95 masks and so forth. For our anesthesia teams, of course, that are going into the airways, they're following the guidance from our hospital epidemiology group on how they mask and how they prepare with gowns for those steps.
Mm-hmm.
But again, these patients that we're operating on are almost always asymptomatic and almost always have been antigen tested, so that there is risk, but it's relatively reduced.
Mm-hmm. Okay, well, speaking of the testing then, what are some of the indications where you would have preoperative testing?
At the moment, for our cases, we highly recommend preoperative COVID testing, ideally at 72 or 48 hours prior to the procedure,
Mm-hmm.
so that we can have results for the procedure and we didn't waste time doing it.
Mm-hmm.
So we recognize that that's an imperfect testing strategy, and expect that it will evolve as we go through the summer and learn more about whether it helps or not.
Mhm. Okay. And are there specific recommendations that you have for specific procedures, specific protocols?
Um, because of the way ophthalmology patients are masked and draped, I think that probably very little is necessary other than normal masking and eye protection are there. Because we don't, as you mentioned, have really very many aerosol generating procedures. And so the risk of the patient who's suitably draped for ophthalmic surgery should be quite low. Obviously, we're going to learn more about that as we go through the next few months, because undoubtedly there will be asymptomatic patients who either didn't screen positive or were never screened, who end up showing signs of the disease a day or two after the surgery. And then you'll say, gee, did anybody get infected who was exposed during that? So there is so much to be learned. And I think right now, it's, as everyone says, this is about making your facility safe with social distancing, keeping your staff safe with that, and then taking care of the patients in a way that you get them seen, managed, and out the door safely, but as quickly as possible. So no hanging out in the waiting rooms
Right.
is probably key here.
Hmm. Okay. And what are you doing to kind of alleviate that stress, or just a different protocol for patients so they feel a little more comfortable about this?
So patients are called to check on symptoms the day before. And if you have symptoms, no worries, we'll cancel the surgery and we'll reschedule it for you. And I think the patients also think the phone call is helpful because it reminds them that we are taking those measures. They also explain that you can't come with the entire family for the surgery, as many patients have done in the past, because more people, maybe a husband comes along with their wife who's having surgery, but then there's the daughter who's driving, and you start ending up with a lot of people. So understanding and explaining the reason for the new rules is really important. And I believe that makes the patients feel safer.
Mhm.
However, there are some patients who feel, and it's absolutely their discretion, that it's not safe to go to a medical setting. And so for the patient who truly has a surgery that can be safely postponed, they should be told that that's a safe decision and no harm. We'll get you back in when you feel comfortable.
Mhm.
So we shouldn't be forcing patients to do surgery just because their name came up in the queue.
Mhm.
There's plenty of work to do.
Sure. And with regard to just this whole situation, obviously a lot of ophthalmologists are incorporating telehealth even more into their practices than before. How have you found that to be factored into your equation?
So telehealth is still somewhat limited in ophthalmology. Unfortunately, we need to examine tissue and structures, and we don't have great tools for that. It's different than interpreting a series of tests or lab tests. Suppose you were doing an internal medicine checkup.
Mhm.
Yes, it would be nice to have the abdomen palpated and the chest auscultated, but you can talk to the patient, you can gain information. In ophthalmology, with the current strategies, we're relatively limited to visual acuity, up close photographs, which can be very useful. And for instance, for postoperative care, may help eliminate some of the visits, but they also would eliminate some of the emergency visits. It's nice to you look at the patient and say, gee, that looks pretty good. I think you can stay home, or that really you need to come in for.
Mhm. Okay. And finally, I just wanted to ask, what has been a positive, or maybe something that you expected or unexpected, a positive to come out of this whole situation with regard to how you approach ophthalmology now?
The biggest positive in my vice chair role has been the way the support and administrative staff stepped up to and managed this particular outbreak and helped coordinate across a faculty of more than 100 providers with 9 sites and more than 1,000 employees. Without that crew and working together, this would have been a bigger disaster. Now it's just a problem. It's a shame, but we've been able to keep going and keep managing and rebooting now.
Mm-hmm. Okay. Well, thank you, Dr. Repka. We really appreciate your time, and best wishes for continued success to you and everybody at Wilmer and Johns Hopkins.
Very much thank you, and you have a good day.